Good morning and welcome to this King's Fund event on community care and housing for people with learning disabilities. My name is Jonathan Holmes. I'm a policy advisor here at the King's Fund and I will be chairing this event. Now, first things first, I'd like to extend a big thank you to the home group who are sponsoring this event and making it all possible. Now, to run through a bit of the practicalities and housekeeping for the morning, we are pre-recording this event. If you are watching this being broadcast live on the 28th of May, then could I invite all of you to submit questions as they arise via Slido. Myself, our panelists, and our library team here at the King's Fund will be going through all of those questions and answering as many as we can and putting them all on the King's Fund website for you to refer back to at a later date. We'll also, over the course of the session, a few poll questions will pop up on your screen. If you could respond to those as they arise, that would be greatly appreciated. Also, if you are a tweeter, you can follow along with the conversation using the hashtag KFOnline. Myself and some of the panelists plan to tweet as this event goes out on the 28th, and you can also look back and tweet about it further along if you're watching back on demand. Now, without further ado, I should introduce our three panelists. So starting off, we've got Rachel Byrne, who joins us from the Home Group, where she is the Executive Director. Then we are joined by Helen Hassel, who is a parent carer with lived experience. He's also a patient lead on and involved in co-production on the Nottingham and Nottinghamshire integrated care system. And then finally, we have Elaine James, who joins us from Bradford Council, where she is a commissioner for learning disability services.
Oh, good morning, everyone, and thank you, Jonathan, for the introduction. I'm Rachel Byrne. I'm the Executive Director of New Models of Care at Home Group. For those of you who probably don't know who we are, we're a national housing association, one of the largest in the UK, and we also have a very significant portfolio of supported housing and specialist housing. I've been in the sector for 30 years and worked as both a one-to-one care support worker in my early days, and have worked with just a small number of organisations around supported housing over those 30 years. Worked across learning disabilities and mental health specifically. Most of our supported housing, particularly now in Home Group, is very focused on those two customer groups. The bits that I'm really interested to talk about is why we're here around transforming care and the work we've done in Home Group. I've learned some lessons on the way around working in the Transforming Care programme. So we invested a number of years ago, about 2 years ago now, in a team of clinicians, of our housing colleagues, care colleagues, and set up a team that would be able to respond to transforming care, recognising that to do that well in housing, you actually need some clinical expertise within your own team to make it happen. And we have, I suppose, actively been working with frameworks and providing property for the last 12 to 18 months. So not that long as yet in the whole scheme of things. And I was really keen that we had this session to talk about some of our lessons and hope that they encourage other providers to join in and pick up the pace on transforming care and come up with those innovative housing and care solutions to make that work. So I am very pleased to be joined by Elaine and Helen, who we'll hear from now, and hope that with your answering your questions, we will have that good discussion about how we can increase the opportunities for people with learning disabilities to move out of hospital and live independently in a home for life, which I believe is their right to have. Thank you.
Excellent. Thank you, Rachel. I think there are things there that we can all agree on. Now, if I could hand over to Helen also to just talk a bit about yourself and your expertise in this area. Thank you.
Hi, thanks Jonathan and thanks Rachel. Hi, my name's Helen Hassel. I'm a patient citizen voice and lead in Nottinghamshire and Nottingham. My background is I've got a 24-year-old with complex needs, learning disabilities, autism. So we've been that long journey so far. We haven't obviously personally experienced the ATU side of stuff, so I will come at it at a slightly different angle. I'm also on the NHS Assembly as a patient voice with my lived experience. I've spent a lot of time supporting families with children with disabilities and special educational needs and disabilities as a whole, which is actually quite broad and quite wide ranging. I think for me, I've seen an awful lot of my friends, as well as myself, see the opportunities or lack of thereof as our children reach transition age and moving into the big wide world. It's presumed that they're going to go to a supported living service. There's very little choice of control, if anything. I've got a young man that was very clear that he said, actually, I want to live at home and I want to be supported to live at home. And it's amazing how long it's taken for people to actually listen to that and allow him to have a voice. As in all things, I'm a fierce advocate of personalised care, and I feel that that really should be the golden thread that runs through everything that we do and is a key part of the long-term plan.
Great. Thank you very much, Helen. Now I'll hand over to Elaine to talk a bit more about her perspective. Elaine.
Hi, thank you, Jonathan, Helen and Rachel. Really appreciate being asked to contribute today. So my name is Elaine James. I'm a local authority commissioner. I also have maintained a research interest and have a research background, which is all in the field of learning disabilities. I've worked for about 20 years now in social care, moving between local authority and voluntary sector organisations. I have a particular interest here because of a frustration about the speed and pace feels very slow in an area where I hear daily a demand for pace and activity and change and difference from people and their families. The last 12 months I've focused particularly around an early help offer in transitions and trying to think really differently about how local authorities can respond and flex and be more creative in responding to people and their families, alongside a piece of work we've done to try to transform our offer for people who are currently in ATUs across the country. And so I really appreciate the chance to share some of that today and also to learn from other colleagues as part of this discussion.
Thank you all so much for going through all of that. You can really get a flavour of the depth and breadth of experience we have on the call. So I'd like to reflect back something that all three of you touched on in different ways around transforming care and also on the long-term plan. So he's talked about the pace of change and reform, particularly around transforming care and how slow it has been. I was wondering if we start off with you Elaine, to sort of talk a little bit about what you think the barriers are to the kind of change that was set out in transforming care and why it's been as slow as it has been.
Thank you, Jonathan. From my perspective, I felt really strongly for some time that the programme being centrally managed is at the heart of some of the difficulties around pace. Local responses, personalised responses that are led by people and families seem to me to move much faster in a local authority than things that are managed centrally and programme managed from a central base. And that Transforming Care feels like a programme that is insufficiently accountable to people and families who are directly impacted on and affected on a daily basis by it. And the challenge that then leads to is that the voice of professionals is really too loud within Transforming Care still. And it still centres around, and we are going to talk about that a lot today, I think, building-based solutions. We sort of move people from one building to another building without thinking about the human elements of how people experience support is actually the people who are supporting them. And that idea that we try to manage risk by building units around people actually just imposes restrictions on individuals that result in escalations of behaviours that can then be described by professionals to justify further and further more restrictive interventions. So if we're going to stop that and break the cycle, the sooner we can look at a national policy response around placing people and families far more centrally to transforming care going forward, the faster we think we can make a change at a local level in a place like mine, like Bradford. And that's certainly what we've done. Over the last 18 months, we have turned commissioning on its head, and we've worked through something we've called the big conversation to put people and families in control of the commissioning agenda for Bradford Local Authority. And we're seeing a really strong and positive change in outcomes for people that's coming out from that, Jonathan.
Brilliant. Thank you very much. We talked a bit about that, about managing risk and building based solutions. I wonder, sort of, Rachel, if I can put the same question to you around those barriers to transforming care, and sort of think about how, as a provider in this space, what your role is in making that change real, and what the issues have been.
So I'll start my answer with, I suppose, a caveat that we are in some ways new to some of Transforming Care. We've been doing it 18 months or so. The supported housing world has always operated in, we need X number of units in a block to be able to deliver this contract for this many individuals. And that's fine, actually, for some types of services. But through our own learning and by bringing in others who understood, it doesn't really work at all for Transforming Care, because there are real individuals who need different solutions, sometimes not as different as everyone thinks they do, but they're different. So we, through experience, realised that the best offer we had was by acquiring a property, so a bungalow in most cases. And we have, I believe, as an organisation, gone a long way, actually, and really reached out. We have worked with the families of those individuals and the individual themselves and clinicians and said, so where would you actually like to live? And at the moment, 9 times out of 10, it's near to family or with family. So we bought bungalows on specific roads in specific communities so that the individual can live there. And then there's an investment, some of which comes through NHS capital as well as our own investment to modify the building. And when we started, as people do, they want everything. And everybody in that group of commissioners, clinicians, NHS commissioners, local authority, and other kind of interested parties all have a view on that. And that's been one of our biggest lessons. Actually, that's quite hard to manage. So it's a shower. Oh, no, it's not a shower. Actually, it's a bath they'll need, and all these varying views. So we've got better at that and are saying this is the kind of basic modifications like soundproofing and different pieces that someone might need. And then we can personalise it. And that means we can go a bit quicker now to purchase bungalows primarily in the right areas for the right individual. And it's not a magic science. We all as individuals have requirements about how we live. And sometimes there are some restrictions just in terms of cost and what you can do. But I wouldn't say we've got it right everywhere. And it has taken probably longer than it should have done in some situations. But I think putting the customer or the customer's advocate and family at the centre of the decision, rather than I feel a bit slightly rude saying this, but rather than a lot of people who think that they're expert in
Mm.
housing and what's needed, it does come back to, thinking about the customer. So I'm really proud of that piece. It's not big numbers yet, but our aspiration is to provide homes to 150 people over the next 2 years, coming through the Transforming Care cohort. So that is actually a big number in this whole scheme of things if you're acquiring separately and so on. I think I suppose what other people I can hear someone saying it as a question, even if they haven't asked it yet, is the economy of scale of doing it like that around individual properties, because you're talking about a care team, a total care team that will be recruited for that property and that individual. And you can, in other situations, put 4 people together and share some of that. So we will try and cluster a little bit in a geographical area, and make some kind of, cost efficiency around that. But ultimately, the commissioned contract, if that pays for that individual's care team, and then we can match that with the rents and the property, that is what we'll do. And I honestly feel that that is what the individual is entitled to, and we should try and meet that across sectors.
Absolutely. Thank you very much, Rachel. So I think on some of those points there, we heard about conversations happening around the individual and their family and their needs almost being secondary to some of the service design issues that are thought through. So I wonder, Helen, if you could talk a little bit about that, if that's something you've got experience of or could reflect back at all. Thank you.
I think firstly, it's absolutely refreshing to hear both Rachel and Elaine talk about the person who's receiving services to be at the centre, and part of that small group is then their families. Sadly, it's often very lacking. I'm not surprised to hear that there is still, even amongst this sector, a very much focus on professionals know best. It's something that we come up against time and time again. Through children's services, you are absolutely, as a parent, seen as that support mechanism, that advocate. But the minute they hit that chronological date of 18, suddenly the young person's got learning disabilities, so they can't possibly be involved in choice making. And the families, oh no, you know nothing now, off you go. And I think for me, it has to go back to the simple, what matters to that individual. And I firmly believe that all people are able to make a decision. Now, whether it's a decision like we would make, perhaps not, but actually I've worked within schools with children with complex needs and with severe communication issues. There are always ways of getting around those barriers. You've just got to be creative and open to the fact that these people actually have choice. They should have control. And actually, they should have a voice that's shouting really loudly to say, actually, this is what I want. And I think it's really sad that in this day and age, people still don't think that those young people or old people with learning disabilities or autism have an opportunity and have a right to live in a home that is very much moulded by the way that they want to live their own lives. And it is really, really exciting for me to listen to these guys talk and realise that actually my experience of personalised care, my experience of bringing up a young man with a wide range of needs and obviously being amongst friends is some really great work being done out there.
Thank you. Helen, I'm going to come straight back to you with one of the questions that we had sent into us earlier, and I'll come around the other panelists with this as well, but it covers a few of the issues that you've talked about a little bit there. So you had a view that from this question, the view is that some people in senior positions in the system don't believe that people with learning disabilities have a right to their own home. So how would you persuade a person who came with that viewpoint that they were wrong, and how would you put over the value of home-based and community-based options to them?
Thanks, Jonathan. I think this is obviously my own personal opinion, but I think social care practitioners are often slightly more able to take on risk. And my NHS colleagues will probably tell you that they're a little bit risk averse. So therefore, the idea of somebody with a learning disability or autism, often coupled with other complex needs alongside that, very much focuses on the medical model of disability, and therefore means that there is a culture change, I believe, that really focuses on personalised care. If that culture change didn't need to happen, it wouldn't be one of the key parts of the long-term plan. And I think we've really got to change the way that we focus on the people that are receiving services. So actually, rather than be very focused on what they can't do, let's really focus on what they can do. It's amazing. You know, we've all got different strengths, different gifts. You know, we're not all the same. And, you know, some of the young people I work with have got the most innovative ways to help support them if you'd only just ask them. And their families alongside those, you know, they've spent a long period of time supporting that person in their family. And they know that what's worked, what hasn't worked. And we really should be focusing on what matters to them, not what matters for them. And I think it's really interesting to look at it in a wider context to that. I believe that all people should choose and have that choice, whether they've got a learning disability or autism or complex needs or mental health issues. They should all be supported to make those decisions and live the life that they want to live. I'm also a very definite advocate of what I call social prescribing and community-based care. So again, part of the personalised care thread and the long-term plan is really looking at that social prescribing network, looking at our community-based assets. And I think, you know, we're living in a COVID era at the moment. And the one thing shouting out loud and clear is how amazing different communities have been about, you know, standing up, getting alongside people in their communities that need that little bit of extra help for a multitude of reasons. So why can't we find a way to capture that, hold on to it, and really allow that to move forward? I mean, I've got a young man that certainly when he left college was very disaffected, disempowered. Fast forward on a few years, and with the help of a personal health budget that we've got and the right care and structure for him, I never see him. He's always out in our community. He knows more people in my locality than I do, which is quite embarrassing, really. So, you know, our communities are our strengths.
Great. So I think I'd like to reflect the same question over to Rachel. And Helen made reference to some things in the long-term plan that around social prescribing and the importance of community-based assets. So if you could sort of respond to some of those points, but think about how you would respond to that person who said that a person with a learning disability should not or does not have the right to their own home.
So I can't help this. I have to say the truth. I might persuade for a little while and then I just tell them they were wrong. I don't see how. It's an odd thing, isn't it, to try and persuade someone. So you could explain. I could explain the reasons why, but ultimately they do have a right. Nobody can say you can't own your own home. It's probably behind that question is all the issue of finances and capacity, but we deal with that in the whole range of activity that individual's involved in, not just the house. So I suppose my kind of only experience that to date has been around signing a tenancy. So we don't necessarily sell a house. We could, though. We do ownership as well. But so the people who've lived with us so far have signed a tenancy. And there were some interesting discussions about that, and a few people needing to be persuaded that they have the right to have a tenancy, which is different from owning, I know. And that's partly capacity, but But what we ended up doing was a schedule that went alongside the tenancy, so that the family could take some accountability and responsibility for the tenancy as well as the individual. And yes, that made sense. The wider bit about community assets and social prescribing. So we run some social prescribing services, and that's for all of our customers, whether that's mental health, learning disability, older people, and they have a benefit. I think in relation to this customer group, it's more about the model of support that you offer that then helps them access what's available in the community, so that not everything is about what happens in your home and with your care team. So our model is called LIFE, which is living independently, feeling enabled, that we've worked really hard to put together, and it's built on the positive behaviour support and it's very person-centred. And then in that plan for the individual's care team, then it's to look at what can you access in that's in the community, and support them to, as far as possible, have a full life by living and experiencing the community as well as what happens in the home. Because I think I'm not trying to stereotype or diss what's happened in the past, but sometimes it can be seen as everything has to happen in the home or the place where they're living, and forgetting that we do need to make sure they have access to other community assets, resources, and the life that others do. So I think that's persuasion, less of telling, a little bit more, and and helping someone live a full life in the community and in their home.
That's great, Rachel. Really appreciate the truth and the bluntness of your response there. Now we'll move over to Elaine now, and I'd really like to hear sort of your thoughts on this issue. But if we could broaden it out a little bit to think about how we can ensure that commissioning decisions reflects some of the informed needs and aspirations that Helen and Rachel have talked about, and sort of think a little bit perhaps about your role in translating those into long-term housing offers for your local area. So Elaine, that's quite a broad big question that I will let you tackle.
Okay, from a local authority commissioner perspective, the starting point needs to be Article 19, the UN Convention on the Rights of Persons with Disabilities, and that right to live independently. We have positive obligations to uphold that. I have a positive obligation to uphold Article 19, which is people's right to choose their place of residence and live on an equal basis with whoever they choose. So remembering that there's an international framework that we work within is a really important start for anybody who wants to work in a field around learning disabilities and practice as a commissioner within that. The second thing is recognizing that within that, people's capacity to make those decisions lawfully should be assumed. So from how I've worked is I believe really strongly that the Care Act brought in two statutory duties, essentially. It brought in a duty to assess need, and it brought in a duty to secure sufficiency of supply. Those two things are completely and intimately interdependent and connected. You can only secure sufficiency of supply as a commissioner if you properly understand what operational colleagues are hearing from people and families when they assess need. And we understand in a really broad way that the expression of need, by right, we assume the capacity of the individual. I have yet to find, I reflect Helen's comments from earlier, I've yet to find a single person who, if you didn't work well enough with and take all practicable steps to make enough adjustments so that you could support and enable their decision making, that they weren't able to tell you something really crucial about what they wanted from their life. And a really powerful example of that for me, a friend of mine, his son, every single day for a year, serenaded the manager of the ATU with Queen's I Want to Break Free. For a year, he was told his son didn't have the capacity to say where he wanted to live. The most capacitous thing I've ever heard is that, and if you make sufficient reasonable adjustment and you understand that music is really important to him and can often be important in the lives of a number of young men with autism and young women with autism, then you can make the adjustment for how you choose to listen. And that's the really central to how we've gone about in Bradford our approach to commissioning. So I've mentioned before we've done something called the big conversation. In the end, that's turned into the big listen, and we've worked really hard to listen and understand. And the top of 4 key outcomes people wanted for themselves, the top thing they wanted was they wanted a place where they could live that they could call home. And they've been quite challenging, I think, with us about what that means for our housing strategy. We had adopted an approach where we were looking at conjugate living approaches, multiple settings, economies of scale that Rachel referred to earlier. Our learning over the last 18 months as we've worked with health colleagues to put together some really quite positive discharge plans that have come into play this year, and we've seen a really positive set of movement around people in our transforming care cohort, haven't been really around that. They've been about really quite bespoke and personalised support around an individual place to live that's very bespokely designed, including garden design, space, exterior space being really important to people. It's been really important to me during COVID to have some space outside. Why would that not be important to everybody? So that's been a really important kind of key piece of learning for us, that thinking that through in a really personal way. And we've also had to think really differently about running costs. And I'm really taken by that question about people's ambition for what they want for their child, and would I want that for my own family member as a commissioner, and what becomes the barrier and the limits that stop me turning that into a strategy and approach for everybody. Well, as a commissioner, the thing that tends to worry me is cost. That's kind of built into our DNA as commissioners. And my challenge to myself that I go back to is, what cost is it if we don't do this becomes a really important question. And in a COVID era, the challenge to myself about conjugate living, is that a safe model? Is that economic anymore as a model with what we're seeing around infection control and reproduction rates for virus? A safe model to me feels to be a model designed around an individual. And if that's a more expensive model, then don't we have a right to not put limits on that? When we work with people and families, what we think might be a more expensive model to begin with very rarely is actually at the end. By the time you've worked through how families actually see support designed around the person and the effect it has some way down the line on how the person behaves and how professionals interpret that behaviour. And if we can think about that in-between bridging point, when I've been in an ATU for a long time and you're now asking me to move home to somewhere else, and you're putting all these strangers in front of me, and in a COVID world they're wearing face masks. Why is everybody wearing a face mask? And the running costs in the short term are always going to be more expensive, but the long-term impact is profound. So we need a long-term plan around this that is really localised, accountable to people and families, and recognise the local conditions and the local housing partners in the room. Because as Rachel reflected, there is no issue that a family or a person can raise that I have yet to find a housing person be unable to come up with a solution. Really good example this morning. We've discussed this morning somebody's discharge who was described to me at one point as being a shredder. Deeply offensive term. What that referred to is the curtain in his bathroom would be pulled. The housing provider has very simply suggested, why don't we just use Velcro? That doesn't sound expensive to me. That doesn't sound like 3-to-1 staff monitoring him in his most intimate private moments. That sounds like a really simple bit of good common sense that was based on the housing offer, having spoken to his mum. So I'll pass you back, Jonathan, if that's all right.
Thank you. That was a brilliant response, quite a good canter through a lot of really difficult issues. Now, one of the joys of doing these chats over web is that I've got a clear view of each of your faces, and I saw, Helen, you were nodding along quite vigorously to a few points that Elaine made, particularly around the economics and the cost, and it not just being about necessarily the lowest cost option, but also thinking about how the more personalized option can actually have the longer term greater gain. And we need to factor in the idea of well-being to some extent in how we think about these choices. So I was wondering if you could sort of chip in a bit on that and tell us why you agreed with Elaine as strongly as it looked like you did.
Thanks, Jonathan, for that challenge. First and foremost, on experience, we have a personal health budget in our home, which provides the structure and the support and the financial support to put an appropriate, personalised, bespoke package of care in to support my young man. We save, on average, around £10,000 to £15,000 a year, because that's how much we underspend on our budget. But actually we get more care, support and bespoke structure around what he needs against what we would have had to use if we'd have had to use specific services. For example, if we'd have had to put him in a day service setting full time, if we'd have had to pay for the extra 1-to-1, even 2-to-1 medical support that he needed. And I think I hear what everybody's saying about the economics. You know, there is not an infinite pot of money. There is no new money. People assume when I talk about personal health budgets that there must be this new magic money tree. There isn't. It's about breaking down those silos and using money differently. And it all starts with a really, really good personal care and support plan. Everything comes on from that. A lot of people focus on the money at the end, but actually if you get the personal care and support plan with, you know, a one-page profile and a really good, thorough, populated document, actually everything stems from there. I've got a colleague that volunteers with me within My Life Choices, and I believe her first year's savings on their budget saved £100,000. So, you know, the precedent has been set. It's about those people that are brave enough to put their head above that parapet, to learn about these personal care and support plans and how to do jobs differently, because savings can be made with far-reaching outcomes for the people at the centre of this, above and beyond what, I mean, even me as a parent, I managed to go on holiday last year for the first time in 26 years of marriage. The last holiday I had on my own with my husband was actually my honeymoon. So, you know, I also echo what Elaine says about thinking about what I would want for my other young man. I've got a 21-year-old. Would I need to stop him living an independent life because he might have some other underlying health conditions? No. So why should it be any different?
Thank you very much. You used an interesting words there, I think. Brave really leapt out for me. And I think sometimes a challenge that providers and commissioners sometimes get is that they're perhaps a little bit risk averse in how they plan care, and seek to minimize risk as much as possible. And that can occasionally be at the expense of personalized care. I wonder, Rachel, sort of going back to some of the questions that we've had in from the audience. Got one about any particular tools that help capture the views of individuals and how to best meet their aspirations, and how you can think about that when designing a home, and sort of if what you can do to be, as Helen says, brave.
So the brave point really for Home Group was making the decision to actually speak about the fact that we were going to work alongside the Transforming Care programme, because we knew all the different risks that had, and part of which is financial. But the decision we took, if we're going to do it, we'll do it really well and we will invest in it. So the steps we took were to have both the clinical team, so we have about 30, I think now, clinicians working across home group. That is not usual in a housing association to have that. And then a central clinical governance team, so we had to put all the right frameworks in for that. And then recruit. We have quite a quirky way of doing recruitment, and it's purposefully quirky to ensure that we get the right kind of colleagues for doing that individualised care. And the other bit is we pay relatively well as well. That is a difficulty. We all know that at the moment in the care sector. If you go with the lowest hourly rate, then there will be complications and difficulties in how you deliver the care. So we took that, and that's why I guess the payback is that we need to make sure we undertake those services for a big number of customers to make that viable. The risk bit is interesting, actually. So whilst we've set it all up, we've developed a new model, we've done lots of work with colleagues about how to manage the risk, it's still when you make that final decision, can we deliver for that customer, that you do get, and I understand it, some nervousness, but I guess the wraparound we give to those colleagues is the thing that enables us to manage the risks, some of which is perceived and doesn't transpire anyway. And the physical environment helps that, but it is really the care and the support that the individual gets that really manages the risk, and working with the family, as we talked about before. But yes, you can do some of it with the property, and that's it. It's not about kind of going back the way to reinforced properties. It's just making sure they're, as I said before, in the right environment, near to family, have big outdoor spaces if that's needed, managing the internal, so we can do lots of things with the internal structure of something we've bought and modify that to support the customer. So I think it's about will at the end of the day. If you're trying to do this to make money from it or be able to do it quick, then neither of those work. It does take time and it does take investment. For a housing association like us, as with others, it's part of our social mission and purpose. We have a charitable status, it delivers against that. And that's the argument I use to make sure we get the right finance.
I think what I'm sort of hearing fairly loudly from you is that in response to that question in particular, is that it's not so much about the architecture of the building, it's the geography of the building, and it's about where the person is, where they want to be, and the networks that they have. Is that fair?
It is, and I thought Elaine's point about the shower curtain, it is actually little things like that the bigger issue above that is trusting experts. So not blindly trusting all experts, but using those expertise from the beginning. So the thing I would really love to see is those initial MDTs, multidisciplinary team, do involve housing from an early stage. If that's what you want, if you want them to, the individual to move out, then have the housing person there. Because what we have found is we get 2 or 3 hand messages that have got a bit lost on the way, and that might be about something to do with the decor or the outside space or the types of windows, actually. And so when you go right back to the source, they'll say, no, that isn't what we meant. So it would be nice or it would be a good thing to have housing as part of the first sessions of those teams, working with the customer to get the best solution.
Great. So I think we're going to get on to another question now that's come in from one of the audience, and I'm going to put this straight to Elaine, if that's okay. And it's a question around the expectations of families, which this person says can sometimes be too high and can sometimes complicate matters. What would your advice be to social workers in your team or elsewhere who report this, and what do you think is the best practice when social workers encounter a family whose wants and needs might be perhaps beyond what you're able to offer?
Yeah, I guess my first question would be, who says it's too high and what are we basing that on? And that would be my first question to a social worker, just so that they can take a bit of time to critically reflect about that and about their own values in action, because there's some quite heavy judgments there being made about people and families. The structural thing behind it is the pressure the social workers are under, which has been an economy and efficiency conversation in commissioning for a long time, and probably has quite a significant contribution to the delays and the frustrations within transforming care as a programme as a whole. And this isn't a programme, when you get down to 2,500 people, 3,000 people, somewhere around that with the numbers, that you can do anything other than be quite bespoke in your response. There isn't a national model probably around what good pricing looks like. There needs to be much higher levels of trust, and the conversation, whether it's with social workers or the commissioners and senior leaders in the system, trust at all levels really matters here. If we can't trust that families are describing the best model for their loved one, and also one that over time will be economic, the first block exists for us being able to move forward collectively to agree what is in somebody's best interest. And if we're going to step somebody down from a section of the Mental Health Act, if we're going to a tribunal, if we're going to court in order to make amendments to safeguards around deprivation of liberty, which nearly everybody in the Transforming Care Group has some kind of legally authorised restriction around them, mainly under the Mental Health Act. I think 8 out of 10 people currently in ATUs have a section of the Mental Health Act applied. Then we are going to need to be able to evidence and uphold in court as local authorities that we have taken all steps to consult and engage and properly hear the views of families, the person and their advocate, so that we are weighing up all options available for any decision to step somebody down and have the best informed basis for that. The court aren't interested in costs, the tribunal aren't interested in costs, they're interested in how well the plan responds to assessed need. And that would take me to my other role for what I really would expect social workers to be. I do want them to be thorny, I do want them to be the challenge, and that's what we look for when we appoint our social workers. Our recruitment now is very heavily focused on social workers who know and believe to their core that their human rights is the purpose of social work. It's part of their global professional calling, and it's why they chose to take that particular route into health and social care. And I would expect and want to see them talking much more about how they are acting as the challenge within the MDT. And MDTs, in my experience, are quite big, and the person and their family might be one person. A care in the CETR process, the children's version of the review process, I think you've got one person you're allowed. I'm sure Helen will correct me if I'm wrong, but there can be up to 20 people in those rooms. Very rarely, to take Rachel's point, is that somebody housing. You might have an occupational therapy professional as part, but actually the housing options might be quite limited to the occupational assessment elements. And my expectation from the social worker is, if you're going to challenge, talk up families' expectations. Listen properly to what they're saying. I have yet to find a social worker whose case, when in court or has lost, where they have agreed and been consistent with the best interest views of the family. I have found social workers get into real trouble where they're in conflict with families and they're in breach of People's European Convention Article 8 rights, which is the right to a family life.
Thank you. Yeah, really good to hear that human rights based approach coming through as strongly as it is. You talked a bit about the size, shape, and structure of multidisciplinary teams. And it seemed to me a little bit that the way we're thinking about this is perhaps a little bit back to front. That the family's expectations can make things complicated, is what it says in the question, but really it seems it's more the system that's making things complex, and families are perhaps just a small cog that perhaps is marginalized within that. I was wondering, Helen, if you could talk perhaps about your experiences there and sort of feeling, have you ever felt like you're the bolshy family member, or is that completely wrong? Let me know.
I think maybe I shouldn't really answer that one. I'm sure there's a lot of people who think I'm a little overbearing, I would probably say. I think it's worth reflecting that if a professional is struggling to understand where families are coming from, it's worth reflecting on the fact that most families have been fighting from nearly the day their child was born. And we have fought, and we have fought, and we have fought again. And we are exhausted. And do we always approach as families the things in the right way? No, because we're tired. And we're fed up of having to justify our position as advocates for our children and young people. And for me, I talk about my child, but actually he is a young person, but it's a difficult thing sometimes as a parent to change your language. So I think for me, I would always ask any professionals that are involved to really come alongside the families and understand the history. You know, if the parents are being a little challenging, there's always a reason for that. And actually, if you can dilute some of that anger and really understand where they're coming from, it all comes down to communication, and really good communication, whether you're a social worker, whether you're a health professional, wherever you're coming at, understand what's gone before you, and then you can then journey forwards together. And I think certainly within, I've done some research within NOTS ICS, and they are certainly doing MDTs with a wide cross section of people. I agree wholeheartedly. MDTs can be really intimidating. Not everybody's got my confidence. Not everybody goes in completely ready to own the floor. So we have to make sure that we give voices to those people that are exhausted, that maybe are that little bit more reticent to speak up in a big room full of people. And we've got to look at whether we can do MDTs in a different way. And have conversations outside of an MDT that are maybe recorded or brought to it in a different format. Often video can work because families feel less pressured to have to go over their story and explain themselves time and time again. So they seem to be working within City, but as Rachel said, a lot of this is really early days and quite innovative.
Great, thank you. I think we're hearing a lot there in response to the question. It's about perhaps returning to first principles of social work, that the family aren't a problem, they are a stakeholder within the care plan, and a vitally important one, and one that perhaps have been marginalized throughout most of their child's life. And of course, as a parent, you're going to have some quite strong views on the life and well-being of your child. Wondering now, going over to Rachel, I was wondering if you have any reflections on that point there around engagement with the family, and how you as a provider sort of fit perhaps within that multidisciplinary team process, and how you and the ongoing long-term support join the dots perhaps between the social worker, the family, and respond within that maelstrom.
I thought you might ask me this actually. So I'm going to give you two quick examples, one where we didn't do so well actually, because you don't learn if you just say we're getting everything right brilliantly all of the time, and one where we did a lot better. We were working with an individual who was coming out of hospital and with his father. Well, I suppose the first lesson in it was we weren't working with them actually. We weren't part of the MDT, and we were in that process of just delivering the property. We weren't going to do the care of, I suppose, second and third hand messages And there were some difficulties with the property, so we were a bit late with that. What I didn't know and others didn't know until we said that it was going to be late in delivery. Only for us, we think, well, only by a month. But of course, the impact that had on the father and his son, who was in hospital, was terrible. And they were very upset about it. But the opposite also happened, that they weren't given a very good explanation either. So I offered to go, actually, and in the end, one of our clinical team went and met with the father and the customer and explained it and our apologies and why it was late. And it's fine, and he's moved in and we've all moved on. But it left us with a very strong lesson that we have to do better than that. One is we just have to do better. When we commit to X on a property, we have to make it happen. But two is forcing ourselves to be involved in those discussions and meet the family. One where we did better, and it's just worth sharing it because I guess it was very much at the start of our work in this, and you can't help but be shocked into acting. So it was a mother and a son. The son wants to live with a mum wants to live with a son, but the whole world around them of different professionals wasn't making that happen. And I think at some points in the process didn't actually think it should happen either. So we reached a point where I think we were referred to as maybe an option. And so he had been in hospital 5 years longer than he needed to be. He was ready to be discharged. But because of this discussion about a property, so, in the end, we bought them a bungalow and he's living very happily with his mum in that bungalow. And we've done that in a couple of instances now, bigger property, and it's claimed through the rent and so on, so that they're able to live there. And we did that really well, but it would be wrong of me to show that as our example and not say that there have been difficulties too in just delivering on time. And I would have found it more helpful had we been introduced into the whole picture sooner. We're not just a property developer that hands over a property. It's so much more than that that's required.
Great, thank you so much. That, I think, feels like a very pragmatic but also optimistic note on which to end this main portion of the discussion. What I think we should do very quickly is go around each of our speakers, and I'm going to put you on the spot a little bit and sort of say, if you could speak a little bit about what your key reflection has been, what your takeaway message for all of those watching this, what your reflection and takeaway is. So I'm going to throw that over, first of all, to Elaine.
Thank you, Jonathan, and thank you for the opportunity to participate, Rachel. This has been a great honour this morning. My key reflection is just really holding on to the points that Helen's made about people and families, and that people and families are tired by the time that they're in the middle of transforming care, and being respectful and recognising that, but also recognising the expertise that they bring and the support we need to give to make sure that that is still at the heart of any plan going forward. And from what I've heard from Rachel and reflecting on Rachel's comments today, apart from now wanting to go away and find out his home group on our local framework, because my goodness, the quality of the offer is profound, Rachel, actually, and it fills so many things that are challenges to me at the moment. Housing absolutely needs to be in the room. We talk about integration as being about integration of health and social care. I often find that strange, because if I broke my leg, I wouldn't want the doctor following me home. So I don't know why, if I have a learning disability, that is ever a thing that we want to talk about, really. I think integrated lives around a person and recognising the centrality to a space where that I call my own, that is where I live, that is my sanctuary, where I can close the door with my own key. That's crucial. And I do think we could absolutely change conversations if we had people in the room from the outset with every conversation that might result in a transforming care admission, and really engaging housing partners in that in a meaningful way, and not then turning it into a vertical integration or a horizontal integration conversation. So those would be my takeaways.
Great. Helen, we can go to you next with the same question.
Thanks, Jonathan. And I suppose my reflection is very much I came to this session feeling very much that I didn't have anything to offer because I don't have direct experience of housing. But actually, I am really excited actually about work being done by Rachel and Elaine to empower people with learning disabilities and autism and their families. And I think it still comes down to choice and control for me. It still comes down to the fact that there are people at the heart of all of this. I would never have thought about having housing into those MDTs right at the very beginning. It's something I will definitely advocate for within our ICS. They're doing some amazing work, and they possibly already do some of this, but it's always worth checking from my point of view. I think long may people like Rachel and Elaine drive forward change, and hopefully it will become contagious, and we won't be reflecting on how many barriers there are in the next 10 years, but actually reflecting on how many barriers we've overcome. So thank you both so much for a really, really great session.
Absolutely. And the final word is going to go to Rachel. Thank you.
I will be quick, actually. So I think it's worth saying that Elaine and Helen and I have never met before. We're three individuals working in different ways in this whole field, and the conversation was way more positive than I expected or hoped for. So it gives me confidence. We're not the only three who are positive about the change that needs to happen. That means there are lots of others, and it's something around that. MDT is a very fancy word for it, but how we make sure the right individuals are working around that customer from the outset. I think, honestly, today's session has been great. Yes, all a bit nervous about doing it virtually, but seems to have worked brilliantly. And I think we've got a whole heap from it. I'm very grateful to both Elaine, Helen and Jonathan as well, how you've steered us through it. And let's just hope that we get some additional questions that we can answer offline and get other people to feel as passionate as we do.
I've got a feeling that that won't be an issue, but thank you. Thank you very much for your time and your expertise. I think listening to all of you over the course of this session, the things that have really leapt out at me are the importance of choice and remembering who this is all about and what the services that we're putting in place are actually for, the importance of human rights and those things that should always be at the core of social work and at the core of our practice, and also the importance, we heard a lot from you, Rachel, about where your home is, how important the place that you live is. It doesn't matter if you have the best house in the world designed by the best architect if it's in the wrong place, because you will be without your networks. So that brings us to the end of the session. So I'd like to take the opportunity to properly thank Rachel, Elaine and Helen as well for your time and for coming here and sharing over what can be quite a tricky and difficult platform from time to time on the King's Fund's websites. And the final thing is, there will be a questionnaire for all of you watching at the bottom of your screens. Please do fill that in and let us know how we've done. It helps us to change and update our events to make them as good as possible. So thank you and enjoy the rest of your days.